Good afternoon, everyone. Welcome to this webinar on advanced applications of lung ultrasound, presented by Drs. Michael Wagner and Keith Barron. Today's webinar will cover findings of viral pneumonia, ARDS, and COVID-19 pneumonia on lung ultrasound. The AIUM is accredited by the ACCME. This webinar is designated for 1 AMA PRA Category 1 credit. By the conclusion of this webinar, participants will be able to recognize findings of viral pneumonia, COVID-19 in particular, on lung ultrasound, describe the findings of ARDS on lung ultrasound, and distinguish findings of COVID-19 pneumonia from other causes of respiratory failure on lung ultrasound. As an ACCME accredited provider, it is the AIUM's policy to ensure that the content and quality of this activity are balanced, independent, objective, and scientifically rigorous. At the conclusion of the webinar, you will be able to access the CME test located on the AIUM website. For more information on accessing the CME test and claiming credit, please refer to the handout provided in the dashboard on the right side of your screen. Participants who complete the post-test with a grade of 70% or higher will be awarded 1 CME credit. All individuals who are in a position to control the content of an educational activity are required to complete a disclosure form. All disclosures are reviewed by the AIUM, and any conflicts of interest are resolved or managed prior to an activity. Dr. Keith Barron, Dr. Michael Wagner, and Darcy Belito de Luna have no disclosures. Credits for this webinar are approved for physicians, sonographers, and radiologic technologists. During today's presentation, if you have questions for the presenter, you may type them into the question box on the right side of your screen. You will be able to submit questions throughout this webinar, but the presenters will not begin answering questions until the end of the presentation, at which time they will answer as many as possible. A recording of this webinar will be available on the AIUM website. And now I'm pleased to begin this presentation with Dr. Michael Wagner.
Okay, thank you to the AIUM for supporting this opportunity, and to all the healthcare workers joining us today. During these challenging times, we also want to thank you for everything that you're doing.
Yes, thanks a lot. And this is Keith Barron. Thank you very much for having us.
These are our stated objectives for this webinar on the use of lung ultrasound for viral pneumonias and ARDS. We should note that we consider this to be an advanced topic meant for those with prior lung ultrasound experience, but also recognize that sometimes in a crisis it can be a strong driver for personal growth and education, so really all are welcome. If you don't have prior lung ultrasound training, do be sure to circle back on some of the introductory lung ultrasound talks that are available either through the AIUM or elsewhere. And so with that, we'll get started. It is fair to say that even before the pandemic, there was a lot of interest in lung ultrasound. And while many holdouts still remain, its use is no longer considered fringe or investigational by a number of major medical groups who may have previously been downplaying it. Lung ultrasound is included in chest imaging in the WHO guidance on COVID-19 and is also recommended by some radiology and cardiology groups. The world certainly does feel a little smaller now, and those in the medical community are leveraging near instantaneous global connections to share ideas and best practices as things change rapidly. With personal ultrasound devices and social media, we find ourselves learning from the lungs of physicians who are scanning themselves in self-quarantine, as well as expert clinicians on the front lines in mass casualty-like situations. And while the impact for all areas hasn't been uniform as a result of shortages, many have found themselves unexpectedly practicing in a limited setting, having to ration many things to include viral testing. Determining who to test, who to isolate, and when someone under investigation was felt to be adequately ruled out for COVID-19 was made even more challenging by initial guidance for screening patients involving insensitive findings like fever or rapidly outdated location associations, as well as a number of reports that suggested imaging, specifically CT, might be more sensitive than the initial PCR tests. Many of these common challenges have those in medicine thinking critically about how we do things during the pandemic. There are some of the frontline who believe that the value of the information obtained via things like auscultation don't really justify its risk, may not even be feasible in settings like this one. There are a number of laboratory tests that we order to help gather data on these patients, but aside from our general collective experience, their utility is really unproven. And while the exact role of lung ultrasound in COVID-19 is clear, it should be emphasized that I think the role of imaging in general in COVID-19 patients is unclear. Certainly, it's done, but not clear what the exact role is from a prescriptive standpoint. And however, we want to emphasize that you can't wait on rigorous evidence-based approaches during a pandemic. We simply have to do the best with the tools we have and continually reassess. And for some of us, that includes using lung ultrasound. Before going into lung ultrasound and COVID-19, we should start with what we know about COVID-19 in general as far as imaging is concerned. We should emphasize we know it causes now a spectrum of disease from asymptomatic or only mild symptoms to very severe pneumonia, up to cytokine storm resulting in multiple organ dysfunction and ARDS. Interestingly, a number of patients without symptoms or very early infection have evidence in pulmonary involvement, which lead to the use of imaging as a screening and monitoring tool in China, described by the article listed here. Like other forms of viral pneumonia, the findings when viewed on chest x-ray are mainly interstitial and inflammation affecting the lymphatics and vascular tree predominant. In addition to interstitial thickening, when the inflammation involves the alveoli, it can cause partial leakage of fluid and proteinaceous material, which gives the affected regions of the lung the appearance of ground glass or opaque glass on CT scan. Unlike other viral pneumonias, COVID-19 tends to be more in the periphery and pleural effusions are more rare. And here's one of our patients who had both a chest x-ray and a CT scan, and we can see diffuse interstitial thickening and some scattered ground glass opacifications extending all the way out to the periphery. Before delving into our preliminary experience with lung ultrasound and COVID-19, it is worth noting that there is well-established body of literature regarding its use beyond just guiding pleural procedures and looking for fluid. If you're not already familiar, a good starting point in the literature is the International Consensus Conference guidelines on lung ultrasound. Many of the lung ultrasound findings seen in COVID-19 are shared by other inflammatory diseases causing pulmonary fibrosis or ARDS and have already been very well correlated with CT. And for many pulmonary conditions, from pulmonary edema to pneumothorax to pneumonia, lung ultrasound has been shown to be more sensitive and at least as specific as chest x-ray. So it's not really hyperbole to say that lung ultrasound is really the best bedside tool for evaluating patients with undifferentiated respiratory complaints. And when particularly paired with cardiovascular ultrasound, it can enhance diagnostic accuracy faster, increase diagnostic confidence, and frequently detects unexpected but significant and impactful findings, some of which have prognostic value. In the time of SARS in 2003, lung ultrasound was still gaining a foothold, so chest x-ray and to a lesser extent CT scan were predominantly used. For the H1N1 pandemic in 2009, lung ultrasound was shown to be highly sensitive in Italian adults presenting with respiratory distress. And for pediatric patients in New York City, lung ultrasound was shown to have high inter-observer agreement for distinguishing viral from bacterial pneumonia, and it was recognized as a useful triage tool. With extensive and initial serial CT data from China, we have a general pattern of disease for those who develop pneumonia. For most patients, initially it starts unilaterally in one or a few mild multifocal wisps of they call ground glass opacities. As the disease progresses, it involves both lungs, and the ground glass opacities become more diffuse, some evolving into consolidations. And you can see intralobular septal thickening bands and band-like consolidations as well. And many of these lesions do reach the pleural surface, so they've been correlated with lung ultrasound findings where they can be seen. This table of CT and lung ultrasound findings is from a letter in the intensive care medicine highlighting the author's experience correlating lung ultrasound and CT in COVID-19. Although it's not peer-reviewed, the key features here listed are B lines, thickening or irregular pleural line, small consolidations, rare pleural effusions, and then sort of a return to A-line pattern with convalescence. In this published paper, the key findings were that although lesions were found throughout the chest in both hemithoraces, as with other pneumonias, the hot spots in the lungs are predominantly posterior and inferior. B lines were the most common finding, but pleural line abnormalities, subpleural consolidations, and interestingly, localized effusions were noted as well. So before we go into detail about how to scan and what these lesions look like, we have to mention the importance of infection control procedures when performing lung ultrasound in COVID-19. When used properly, ultrasound can actually help conserve PPE and reduce exposure to other healthcare workers, particularly being performed by the treating clinician. But if you have never heard of List N from the EPA or have no concept of what a wet time is or don't have a plan in place to prevent contamination, this is a hard stop here until you do. Check out the resources on AIUM's webpage if you have additional questions on this. As far as which probe most favor, using a convex probe for most of the scans, sometimes switching to the linear for detailed assessment of the pleural line. And that's what we will cover in this talk. If I had to just pick one probe for the lung and for the best pictures, I personally would pick the convex. But if using as part of a multi-system approach and examine the heart, lungs, abdomen, things like that, I often will just use the sector, and that seems to work just fine. The standard approach for dividing each hemithorax into the anterior and lateral zones, as well as superior and inferior, is often utilized, particularly in the supine patient, and seems to be pretty much standard across ERs and ICUs. Because we are talking about pneumonia, however, accessing the posterior lobes by having the patient sit upright likely improves the sensitivity of your scan and is recommended in this proposal for standardizing lung ultrasound exams in COVID-19. If this isn't feasible due to the critical illness or the patient cooperation, one thing to consider is timing your exam to correspond with the patient's turning schedule, or if they're getting meals and things like that, having somebody else in the room to help you who's going to be there anyway. This is just to draw your attention to this article published in the Journal of Ultrasound and Medicine. It seeks to standardize how we examine and monitor patients with COVID-19 using lung ultrasound, and their recommendations on using a scoring system that they developed, which includes B lines, pleural changes, and consolidations. It's a 14-zone method, and it's mainly for research standardization and should not be considered sort of mandatory for clinical practice, which will often be much more sort of focused based on the clinical question at hand. But be sure to check this article out and also tune in for an online interview with some of the authors in another AIUM webinar next week. Our scanning technique for pneumonia really has evolved over the years, often starting at the posterior bases, at the diaphragm in upright patients, or in the supine patients, sort of at that so-called PLAPS point, and sliding from the diaphragm or that area sort of superiorly as we're able. The diaphragm is the start point as well for the superior sort of slide when in the lateral and the anterior areas as well. And it's less about a point exam and more sort of a dynamic, big sweeping movements over the chest as you kind of work your way up. Some people have described sort of a lawnmower technique, kind of going back and forth, but it's really sort of a big sweeping movements. And then when you detect abnormalities, then it's small sort of micro movements to adjust. Posteriorly, sometimes the oblique position of the probe to get in between ribs is helpful. This is less critical for the lateral and anterior areas, in my opinion, but can be very helpful, especially if you have kind of these tiny consolidations and getting them to come out from behind a rib. Finally, it's important to remember that lung ultrasound is all about maximizing artifacts. The machine settings and the equipment can really be a factor here. I do want to say that some of the terms we commonly use to describe lung ultrasound findings, like subpleural consolidations, were really borrowed from chest X-ray or CT scan, and we need to exercise caution here. We do detect lesions like ground glass opacities or crazy paving patterns that are seen by CT by way of the vertical hyperechoic ultrasound artifacts that we see on the screen. But we don't necessarily see these things directly. And we comment that the visceral parietal pleural interface, or the pleural line, often appears thickened, but we should remember that this is not necessarily a true reflection of the thickness of the visceral or the parietal pleura. Furthermore, the most prevalent findings in viral pneumonia and ARDS are hyperechoic vertical artifacts. And while consensus among experts was published about B-line artifacts in 2012, our understanding of these phenomena still is evolving, and we have a lot to learn still. So moving on into the actual artifacts and the findings, this small study in Italy looked at lung ultrasound, chest X-ray, and CT in a subset of COVID patients, and also confirms the most prevalent finding is the B-line artifact. So that should be your primary focus. A low-frequency probe is best to detect B-lines. If we place the probe over the area of the normal lung, make the ultrasound image sort of approximately to scale and superimpose it. This is the orientation, and here we can see you have the pleural line and an A-line pattern below. Here we have the normal A-line pattern here with lung sliding, as we're hopefully used to seeing by now. This is in the sagittal plane using two ribs to frame the image, two A-lines visible. Some hyperechoic vertical artifacts coming down from the pleural line are referred to as B-lines and are felt to arise from thickened interlobular septae. Though the exact pathophysiology for all vertical hyperechoic artifacts that are commonly referred to as B-lines is actually somewhat debated. Here is an example of multiple B-lines, which are the marker for the so-called interstitial syndrome. And then in this clip, we can see initially multiple separate B-lines on this half of the screen here. And then as the patient exhales on the right-hand side of the screen, you see coming in, we have multiple B-lines that come together and fuse to produce the so-called sort of white lung pattern. And unlike in cardiac-induced pulmonary edema, where this pattern is only seen in patients with severe disease and respiratory failure, confluent B-lines are frequently seen in viral pneumonia and ARDS, even if early in the disease process, and can be isolated and separate from other B-lines, which is important. Here's another example of the white lung pattern, this time caused by inflammation. This image appears brighter as the beam is brought more perpendicular to the pleural surface. So a little bit of probe manipulation happening here. In patients with COVID-19, this fused or confluent B-line pattern seems to correspond well with the kind of ground glass opacifications you see on the CT image here. Here being kind of a fused B-line here. In addition to isolated fused B-lines, the overall distribution of the B-lines is the most important when comparing it to, say, cardiogenic pulmonary edema. COVID-19 tends to follow the same pattern as ARDS. While worse posteriorly and dependently, the overall distribution has a very much a patchy distribution. And again, the correlation with B-lines and ground glass opacities and interstitial thickening and scarring on CT scan has been seen in many inflammatory lung diseases, including the fibrosing ones. So these findings are sensitive but not specific. Although both hydrostatic and inflammatory pulmonary edema can have diffuse B-lines throughout the chest, one finds that the most helpful finding often is that it's most sensitive and specific in distinguishing ARDS from heart failure is the presence of these so-called spared areas, which, as best I can tell, was first described by Capetti and his colleagues in 2008. What I mean by that is sometimes less commonly called a skip lesion, but essentially it involves a normal lung that's juxtaposed to a background of surrounding B-line pattern. So here, this is one rib space that's normal. Everything looks great. And then one rib space away looks completely abnormal. Kind of like a lung point in pneumothorax, it's best to capture the transition of this in one clip. So here you can see normal A-line pattern here, transitioning into a B-line pattern there. And then using a CT as an example, we're just trying to capture the region of normal lung on the left-hand side and the abnormal lung kind of on the right. Here's a high-frequency probe showing another example of this transition here. You see it almost looks like the image is cut in half down the middle. And then this is a high-frequency probe compared to a low-frequency probe showing essentially the same phenomenon. The lines coming in with respiration right next to an A-line pattern. While B-lines are not specific, some experts are seeing a pattern that may have a better positive predictive value. In this article, which is hot off the press from the Ultrasound Journal just in the last few days, some thought leaders in lung ultrasound feel that a fused B-line on the background of a smooth pleural surface surrounded by A-lines, or something they're calling a light beam, which might be a specific finding in COVID patients with liver disease. So some summary points for B-lines, and it's the primary lung ultrasound artifact of interest for viral pneumonia, ARDS, and COVID-19. Fused B-lines are common in COVID-19, and then the overall pattern sort of depends on the stage of the illness, the timing, and how long they've had symptoms is really important there. Using B-lines to focus your scanning in different lung regions was something that we really took away from our WinFocus training when we were in Italy. Kind of using the B-lines to really hone your search for associated pleural changes or consolidations. So the big visits, B-lines, big movements, and then focusing in once you've located them. And then spared areas are felt to be relatively specific for inflammatory pulmonary edema.
So now we'll turn our attention to analyzing the pleural surface. Here you can see an example of a normal pleural line with a normal lung sliding artifact visualized with a high-frequency probe with the ultrasound image superimposed over top of the CT scan. And here we see an example of reduced lung sliding but no pneumothorax due to inflammation and adhesions of the lung, attacking the visceral pleura against the parietal pleura, the chest wall. This is also confirmed that there's no pneumothorax via M mode as the beloved seashore sign. Here are other clips using different probes. So on the left is the high frequency probe showing diminished lung sliding or absent lung sliding with a very irregular pleural surface. On the right you can see a low frequency probe with B-lines coming from the pleural line, an irregular pleural line appearance, but absent lung sliding there. So looking pretty similar between those two things, detectable with both high and low frequency, perhaps a little better with the high frequency. Here you can see a normal thin pleural line on the left-hand side, and on the right-hand side you see the thickened or irregular appearance of the pleural line with some vertical artifacts coming off of it. This is sometimes referred to as a thickened or irregular appearance, or discontinuous or fragmented pleural surface. Here you can see the same thing, only with a different machine, a thin pleural line on the left and a thick irregular pleural line on the right. And here you see a thin pleural line on the left with a low frequency probe compared to a thick pleural line on the right-hand side. Again, this thickening of the pleural line on the right, it does appear to be grossly thicker, but it is not a true reflection of the actual thickness of the pleura. It's an artifact. This is comparing the high-frequency probe on the left in the same patient in the same location with the low-frequency probe, so just getting a sense of the differences between the two. On the left of the screen here, you can see that these spared areas are frequently also associated with pleural line irregularities where there are B lines, and that's a finding seen in ARDS as well as COVID-19 pneumonia. So pleural line summary, an irregular or discontinuous thickened pleural line is common in COVID-19 pneumonia, but it's also seen in many other inflammatory and fibrosing lung diseases, so it's a non-specific finding. It's usually associated with B lines, but a thickened pleural surface or an abnormal pleural appearance may remain without B lines during the convalescent period. And then spared areas is felt to be a relatively specific for inflammatory pulmonary edema, ARDS, but is also seen in COVID-19 pneumonia as well. Moving on to consolidations. One pearl from the Italian masters that has really stuck with us is the use of B lines to guide the search for consolidations. Searching for consolidation without at least 1 to 2 associated B lines is generally not terribly fruitful, while tracing a prominent B line back to the pleural surface can be very high yield at unearthing consolidations. In the hunt for pneumonia, it's important to remember consolidated lungs. They come with a differential diagnosis, and just like with X-ray and CT needs to be correlated clinically. It's just an imaging diagnosis, not a clinical diagnosis. So consolidated lung, in general, on ultrasound, loses its artifactual appearance and looks like liver or spleen tissue. In viral pneumonias, the consolidations usually are not very large, as is shown in this example here. Here you can see what we call hepatization of the lung, where the entire lung is consolidated, so you can see it sort of wiggling around inside the chest. Most of the time in viral pneumonia, you really need to zoom in on the pleural surface. Here you see what looks like a smooth pleural line with multiple B lines, but then when you decrease the depth and zoom in, you and make small adjustments of the probe, you unearth these very discontinuous pleural surface here and some subpleural consolidations associated with it. And here is another example of a subpleural consolidation where you have the pleural line right here and then just a little chunk taken out of the pleural line, this fragmentation sort of being a source for subsequent vertical artifacts behind it. And you can see the outline of the consolidation there. This is another example of subpleural consolidations. Here you can see coming in and out of the probe is a smooth pleural line and then a chunk taken out of the artifact and with a tissue-like appearance just beneath the pleural line. And this is a more typical viral subpleural consolidation in sub-centimeter size here, just right underneath the pleural surface associated with a irregular pleural line. I should note that there is generally good consensus about calling subpleural consolidations as opposed to consolidations when the lesions are less than 1 centimeter. When it's greater than 2 centimeters, people tend to just call that consolidation, sort of a gray zone between 1 and 2. But we also sometimes see lack of agreement between even experts between what is a discontinuous or fragmented pleural line and what is a pleural line with subpleural consolidations. Here, these are much larger consolidations that would not be consistent with a viral pneumonia unless they had associated bacterial pneumonia on top of that, or this was from an ARDS patient and these were taken posteriorly. These are quite large consolidations with visible air bronchograms, which would be atypical, can be seen in viral pneumonias, but is highly, highly atypical. Keith is going to talk a lot more about the difference of the air bronchogram, static and dynamic, being used to distinguish viral from bacterial. In this clip here, we can see a pleural effusion as viewed with a high frequency probe, one that kind of comes in between the parietal pleura of the chest wall and the visceral pleura of the lung surface here. And you can see how this could be confused as a subpleural consolidation, but clearly there's a difference between the lung here and the parietal pleura, and it's separated by this anechoic space. So this is a pleural effusion as a mimic for subpleural consolidations. And then this clip here shows a small pulmonary infarction where there is a clear chunk taken out of the lung artifact pattern here with tissue artifact, but it has more of a V shape, and this is in conjunction with somebody who has a pleuritic chest pain syndrome and has actually VTE disease. So this is pulmonary infarction. So take-home points about consolidations. B-lines are often used as your marker to look for consolidations and hone your eye. Remember that when you see a consolidation, it comes with a differential, just like with any imaging modality, and the clinical correlation is absolutely essential. Consolidations that are viral tend to be small and less than 1 centimeter in size. 1 to 2 centimeters, maybe a gray zone. Most greater than 2 centimeters are no longer kind of characterized as subpleural consolidations and just called consolidations. And you want to consider bacterial cause. And consolidations from COVID-19 and ARDS are often posterior and appear later in the disease. If you see large consolidations anteriorly, suspect something else contributing to that. Touching briefly on pleural effusion, the standard method of looking for pleural effusion would still apply, using a low-frequency probe with the diaphragm and the spleen as the acoustic window to see at the base of the chest. Looking for anechoic regions of fluid. Here you can see on the left a large left-sided pleural effusion with compressive atelectasis and the lung just floating around in the fluid like a jellyfish. Here you can see a much tinier little triangle of fluid just above the diaphragm. This is much more characteristic of what you'll see in viral pneumonia, specifically in patients with COVID-19. This suggests some other process is going on that is not accounted by the viral disease. And then here is a pleural effusion, again viewed with a high frequency probe. If you're up in the chest, you might see local collections of pleural effusion, according to some authors. Take-home points. Large pleural effusion should not be associated with COVID-19, but shouldn't really rule out the disease itself. Can decrease the pretest probability, however. And small effusions, look for them really later in the disease, as several days into their course, or in patients who develop ARDS. Finally, we'll correlate lung ultrasound findings with the severity of disease at all time, making sure that the lung ultrasounds match the patient in front of us. In patients with diffuse A-line pattern across the chest in somebody who's very sick and respiratory failure and hypoxemia, that should pretty much rule out viral pneumonia and ARDS as a cause for that respiratory failure. It might even rule out COVID as a cause for that respiratory failure as well. But that being said, we are seeing in some of these COVID-19 patients, just like with children and viral lung infections, the lung sometimes looks much worse than the patient does in front of you in terms of their clinical phenotype. Might not require oxygen at all and still has a diffuse B-line pattern. So this is the same as with chest CT as we're finding, but just needs to be taken into consideration. So now we'll turn things over for more clinical context with Dr. Barron in cases.
Thanks a lot for that. All right, so we'll go ahead and get started. So we'll run through some cases here, and we'll first start off with a classic COVID-19 case, kind of summarizing and putting together all these findings we just discussed. First, I'll show the traditional chest imaging chest x-ray, and CT that showed bilateral patchy subpleural opacities at the peripheries of the lungs, consistent with COVID-19 pneumonia. This is a CT scan obtained from the same patient. She was intubated at this time in the intensive care unit, and we see bilateral subpleural ground glass opacities and consolidation as well. Evaluating the anterior portion of her chest, she mainly had an A-line pattern, and this is somewhat consistent with the CT scan that showed that the apices of the lungs were clear of peripheral disease. We do see an area of fused B lines here, but that was pretty much the only abnormality at this intercostal space. As we move over to the axilla, now we're seeing more of the fused confluent B lines, or the whiteout of the lung. And so this is patchy in distribution. And as we move over to the left hemithorax, we see areas of fused B lines as well as an area of spared pleural line right here that looks smooth, versus over here it looks a little bit more irregular and you have fused B lines. This is in the axilla, and again, we're seeing similar findings. We're seeing an irregular pleural line. Of note, we're not seeing any sort of subpleural consolidations at this point, mainly just an irregular pleural line and fused B lines. Posteriorly, this is multiple intercostal spaces showing a technique where you don't have to necessarily place the probe just in one spot. You can slide down and examine multiple intercostal spaces looking for focal abnormalities. And we're seeing several of the same findings where we have spared or skipped areas with focal or confluent B lines adjacent to this. On the contralateral hemithorax, we're seeing very similar findings as well. This is the same patient 1 day later. Now at the base of her lung, we're seeing a subpleural consolidation. And so this is the irregular pleural line. We have a little bit of a shredded pleural line here, and we're seeing a subpleural consolidation. And then a couple of days later, this is using a different machine, but posteriorly, now we're seeing an area of larger consolidation, subpleural consolidation. This is still not very large as compared to some bacterial pneumonias, but again, we are seeing progression of findings. Of note, the patient's respiratory status at this point remained about the same. And so this is what we're seeing, is that sometimes these patients can have changes in the lung ultrasound pattern, and this is not necessarily correlating with the severity of the illness. In this next case, we're seeing some findings consistent with viral pneumonia, where we have fused B lines, irregular pleural line, and spared areas. But this patient was admitted to the hospital and incidentally found to have SARS-CoV-2 infection with COVID-19, but she had no respiratory distress, no hypoxia, only had a mild fever. And so it's important to note that just because you're seeing these ultrasound findings diffusely does not necessarily mean that the patient is going to develop respiratory failure. And indeed, following this patient over the course of a week, her lung ultrasound findings persisted, but her clinical status remained stable. Sorry, I'll advance the slide here. I put this up here because this is a patient, and we're seeing a mild to moderate size pleural effusion here with some atelectasis at the lung base. And this patient had developed worsening renal failure and oliguria, and so this patient had a pre-existing history of heart failure with preserved ejection fraction. And so we're seeing pleural effusion in this case, although he did have diffuse findings otherwise consistent with COVID-19 viral pneumonia. So just because in the literature it is saying that pleural effusion is rare does not mean that this rules out COVID-19, particularly because these patients, as you track them through the course of hospitalization, are at risk of developing complications, and in this case, he developed renal failure. Now I'm going to run through using different machines and probes, and so many of these findings we've picked to show kind of the best images, but just showing that with different settings, different machines, these findings can be a little bit different in appearance. This is a laptop-sized machine using a curvilinear probe. We are seeing some of the irregular pleural line, very small subpleural consolidation, and some diffuse B lines. This is a tablet device, and so we're now seeing some of this, potentially even the light beam sign here, although I'm not exactly sure about that. But we're seeing some irregular pleural line, fused B lines. This is at a decreased depth, just to focus on that irregular pleural line right in the middle here. This is a handheld probe with abdominal preset, just showing different appearance of B lines in the pleural line. And so we've mainly incorporated tablet and handheld devices in these cases. I just want to note, because they're the easiest to bring into the patient's room and clean, and they don't require cleaning a much larger machine to reduce time spent in the room and infection control later. Now this is a handheld device on a lung preset. And so we're going through and seeing several different areas here. And we're seeing some B lines on the left. Over here is an area that's spared. And then over here, we're seeing some small subpleural consolidation. This is a handheld device that plugs into your smartphone in this case. It's also possible for a tablet. And this is multiple intercostal spaces showing those B lines, the irregular pleural line, essentially lung whiteout in some cases. And this is over here as well. We're seeing some irregular pleural line and fused B lines. This is the same device, but with different presets. And so you can see that the whiteness of the lung does depend sometimes on the preset that you're using. And potentially this consolidation is appearing a little bit better with the lung preset. But again, you can use whatever presets your machine has. I would just cycle through them to find out which preset and probe will maximize the artifactual patterns that we're seeing here with this disease. So now we're going to move on and show a couple more examples of other viral pneumonias. And these are patients, pediatric patients that had confirmed influenza. And this is a somewhat common pattern that you can see in viral pneumonia, particularly in children. And we're seeing subpleural consolidations, B lines, and then there's a spared area over here. This is a somewhat larger consolidation, and I apologize for how much the probe is moving, but in smaller children, sometimes the images are a little bit shakier. And this is a somewhat larger consolidation seen in influenza as well. And so there's some debate about how large the consolidation needs to be before you should consider superimposed bacterial pneumonia. But I'm just pointing out that we're seeing several similar findings of COVID-19 as in other viral pneumonias, and it can be very difficult to differentiate between or among them. I put this up here. This is a 4-year-old, fairly well-appearing child who tested negative, as well as his sibling and one of his parents, for SARS-CoV-2. They all had a fever, cough, and he had findings of fused B lines and an irregular pleural line. And so in this case, this was an unspecified viral illness. And so you really need to consider the prevalence in the population of SARS-CoV-2 because that will affect the positive predictive value of all of these findings in your evaluation of these patients. So putting it all together, many of the findings of viral pneumonia overlap completely with COVID-19, which is another viral pneumonia. They appear very similar to findings in ARDS, and so you're having many of the same findings, including possible consolidation or subpleural consolidations as ARDS progresses. What is different, however, is that cardiogenic edema, like Dr. Wagner was saying, is more homogeneous, and you have fewer pleural line irregularities or skipped or spared areas. Pulmonary embolism can cause a variety of different patterns. Bacterial pneumonia generally has much larger consolidations with air bronchograms in them. And so a lot of the findings of COVID-19 are somewhat non-specific, although they are fairly sensitive. I will point out here, though, that if you have no B lines or the other findings consistent with COVID-19 and the patient has respiratory failure, and particularly gas exchange issues, you really should consider alternative diagnoses, including asthma, COPD, or potentially even pulmonary embolism. So this is a patient with ARDS, and patients with COVID-19 infection are at risk of developing ARDS, and so really it can be difficult to determine the difference between the primary infection and development of this. This is a patient who has an irregular pleural line with a diffuse B-line pattern, but as well as some skipped or spared areas. And I put these 3 clips up here because they very well could be from the same patient. These would be consistent and compatible with each other for possible COVID-19, but these are all clipped from different pathologies. So this is from ARDS on the left, influenza in the middle, and then a patient with COVID-19, all using the same type of probe. So now I'll talk about a case of cardiogenic pulmonary edema, since we've seen several cases of viral pneumonia and ARDS. In the left hemithorax, we're seeing some B lines. The pleural line appears smoother. As we move over to the axilla, as well as down to the base of the lung here, we're seeing B lines that are more homogeneous in appearance. We're also seeing potentially a very, very trace pleural effusion and potentially some atelectasis. As you move over to the right hemithorax, we're now seeing multiple B lines. These are fairly homogeneous. And these in cardiogenic pulmonary edema, it's a hydrostatic process generally. So these findings are more diffuse throughout the chest without all of the spared or skipped areas, and usually without the pleural line irregularities. And then we're also seeing a pleural effusion here on the right, a small one. And so this is more consistent, particularly if you paired it with inferior vena cava and echo findings. This would be consistent with cardiogenic pulmonary edema. It's important to note that using different probes can make this the appearance of B lines look different. And so if you use a linear probe here, we're seeing a different B line pattern as opposed to a curvilinear, and before we were using some phased array probes. Bacterial pneumonia is a risk for patients with COVID-19 to have this superimposed on their illness, although at this point reports are that it is rare. But it's important to go through the findings of this to help differentiate from COVID-19. As we see on the right thorax, this patient has an A-line pattern. But as you go down to the base of the lung here, we see a very large consolidation with hyperechoic branching linear artifacts consistent with air bronchograms. And even right here, there's a question of the dynamic air bronchograms, which raises the probability of bacterial pneumonia. And usually this is, while it can be bilateral, you have larger areas of consolidation. You may have some surrounding B lines, but often you don't have the findings of diffuse B lines and skipped spared areas. Here are 2 more examples with handheld devices of bacterial pneumonia. And so we see here, these are the dynamic air bronchograms, or the hyperechoic artifacts moving up and down with respiration, and a viscous medium, or probably a pus-filled bronchus here. And this is a much larger consolidation over here. As you can see, these appear very different from the smaller subpleural consolidations we were reviewing earlier. Now, I did put this up here because this is a patient that we actually tested 3 times for COVID-19, because the initial chest x-ray and lung ultrasound findings, as well as clinical symptoms and exposure to someone with COVID-19 very much raised the probability of that disease. And we're seeing lung whiteout here, fused B lines. There were some skipped and spared areas. And then over on the right side of the screen, we're seeing some subpleural consolidation moving in and out. But after a CT was obtained in this patient, it was determined that she probably had multifocal bacterial pneumonia, and in fact ended up having a positive culture in her blood. And so I put this up here because we had such a high suspicion for COVID-19 based on these findings, but indeed there was a different etiology of her respiratory failure. Pulmonary embolism is being increasingly reported. Venous thromboembolic events are becoming increasingly reported with patients with COVID-19. And so I put this up here to show that we're really not seeing a diffuse B-line pattern, although that is potentially possible. And we're seeing less of a regular pleural line, but we're seeing more of a punched out lesion here of subpleural consolidation without necessarily surrounding B lines or pleural line irregularities. I would like to note that lung ultrasound does not rule in or rule out pulmonary embolism, and it's best used in conjunction with a full body ultrasound protocol, incorporating heart, inferior vena cava, and venous ultrasound. But I did put this up here. This is a patient who had evidence of right heart strain, which increased the probability of pulmonary embolism, and a deep venous thrombosis was found as well. So putting it all together, this is a patient who had classic lung ultrasound findings of COVID-19. He was transferred from the intensive care unit. His inflammatory markers initially improved, but then they worsened. He had worsening respiratory status, and so a lung ultrasound was performed to evaluate for superimposed pathology. And what we're seeing here is a larger area of consolidation than we had previously seen. There's also a question of possible dynamic air bronchograms, but we're certainly seeing some branching linear hypercoic artifacts consistent with static air bronchograms. So the suspicion for bacterial pneumonia was increased, but the patient then had a CT scan that showed a large pulmonary embolism. And so the radiologists called this area here a possible consolidation consistent with pneumonia versus a pulmonary infarction. And as we know, this can be difficult to tease out how much, whether this is bacterial or pulmonary infarction. So these patients are at risk of many other things that can be superimposed upon the primary COVID-19 viral pneumonia pattern. And lung ultrasound can help follow up these patients, particularly if the clinical status changes. So putting it all together again, we discussed how patients with COVID-19 have findings consistent with other viral pneumonias. It appears very similar to how ARDS has been described in the literature previously. It is distinguished from cardiogenic pulmonary edema by the diffuse peripheral patchy distribution. But these patients are also at increased risk of pulmonary embolism, bacterial pneumonia, potentially even cardiogenic edema if there's some cardiac toxicity or shock. But if the patient has respiratory failure without any of these findings diffusely, then you should really consider other alternative diagnoses. And so to kind of wrap it up, lung ultrasound in COVID-19 is probably helpful in the sense that if you have a diffuse A-line pattern, it could help you consider alternative diagnoses, particularly if the patient has respiratory failure or gas exchange issues. It may support the diagnosis of COVID-19 when rapid PCR is unavailable or initially negative, particularly at the beginning of this outbreak in the United States when we were waiting days for these results to return. It may help guide admission versus discharge in borderline cases. At this point, we're not exactly sure whether rapid progression of findings is correlated with prognosis, but this is being investigated. It may be helpful to determine who should get antibiotics, such as that patient we were considering superimposed bacterial pneumonia in. And it's probably best used in a whole body ultrasound protocol looking for concomitant venous thromboembolic disease. It's probably not helpful to exclude COVID-19. It probably is not helpful in determining who needs treatment. It's probably not helpful in determining infectiousness. This is a protocol that we came up with. This is unpublished and is not peer reviewed, but this is based on our own expert opinion and in conjunction with discussing with other people who are managing these patients. But the clinical presentation is probably the most important aspect of management of these patients. The role of chest imaging, as Dr. Wagner said, is still not quite known at this point. But in patients who do have respiratory distress or hypoxia, and lung ultrasound is used, showing a diffuse pattern consistent with the disease, this probably should prompt admission to an isolation unit or presumptive treatment. If the patient has respiratory distress or hypoxia, the decision to admit is probably already made, but lung ultrasound without diffuse disease should help prompt looking for other alternative diagnoses, for example, COPD, asthma, pulmonary embolism. If the patient does not have respiratory distress or hypoxia, then you should probably do a risk factor assessment, and then lung ultrasound in this case could help determine whether the patient without these findings could potentially be discharged home with home monitoring and isolation pending results, versus if the patient has diffuse disease on lung ultrasound, that should at least prompt consideration of risk factor assessment. You may want to consider close outpatient monitoring versus observation, depending on the risk factors in these patients. And at that, we'll move into questions. I've put the slide up here. We're always happy to answer questions and discuss this further, especially as the literature grows and we have more experience with managing these patients. I put this up here. This is Mike and I examining each other at about 9,000 feet elevation, looking for altitude-induced pulmonary edema, showing that these handheld devices really are quite portable. And I'm just going to go through the references, pausing briefly in each slide so you can return to it later.
And the references are also available as a handout on the right side of the screen.
All right, well, thank you.
Perfect.
Great. I'll go off some questions. Keith, I'll start with some questions for you. Coming from, let's see, Molly, who has a question about air bronchograms and COVID-19 viral pneumonia. Are they seen in this disease process, or is this mostly in bacterial pneumonias?
So the definition of air bronchogram on lung ultrasound generally refers to the presence of branching linear hyperechoic artifacts. And so anecdotally, what is being reported is that these patients have few of these, although they have been present in several of the slides I showed in other viral pneumonias. I've seen these. If you look at cases or other publications where they've looked back at whether branching air bronchograms increase the probability of bacterial pneumonia, there's been a correlation. But I do not think that just the presence of air bronchograms should rule in bacterial pneumonia. If you have particularly a unilateral consolidation with larger areas of air bronchograms, particularly if they're dynamic, this would be more consistent with bacterial pneumonia. I hope that answered your question.
Okay, great. From Elizabeth, what settings should be utilized to really optimize the image when searching for viral pneumonia and ARDS in lung ultrasound?
Mike, do you want to answer that, or you want me to?
You can answer.
Okay. So it really depends, and so it can be tough if you're just learning this. But what I would recommend is in a patient who does not have COVID-19, who may have pulmonary edema, for example, is to take whichever machine you do have, try out all the different probes and different presets to determine which one highlights the B lines the best. Remember to fan the probe, sometimes subtly rotate it to crisp up the pleural line and increase your ability to image these artifacts. If your machine has a lung preset, that's probably the best. That generally strips away some of the software that the machines have added on to help image the heart and the abdomen. But in the absence of that, go through cardiac or abdominal presets. I don't know if you have anything else to add, Mike.
I'll add, if you're using a high-end machine and you can change the focal zone position should generally be at the level of the pleural line. That's something that we commonly kind of mistake or leave out when we're in a hurry and people are sick and things like that. But if you're doing a nice exam, try to put the focal zone at the level of the pleural line. And then one thing I've noticed in some machines, they've really gotten the lung preset down correctly. In others, the lung preset seems more geared towards highlighting the B lines and making the B lines stand out, but are less useful when assessing for consolidations or for pleural effusion. So yeah, as Dr. Barron says, lots of depending factors there. Next question from Ami. Non-intubated patients, do we think lung ultrasound can predict severity of disease and help in risk stratifying these patients? Because you kind of touched on that initially towards the end there.
I think that that's experimental at best at this point, and it's based on anecdotal evidence. And so I have not personally seen many algorithms incorporating lung ultrasound to necessarily predict who requires intubation, although I've heard people say that if you have gas exchange issues and diffuse disease, I know some people are preferring early intubation. But again, I think at this point, there are so many things that are unknown, and I think there's a heterogeneity of clinical practice that I cannot recommend that at this point. I don't know, Dr. Wagner, if you have different experience.
No, I think that's fine. I think it's just a lot we're not quite sure about. Some people are reporting in their experience, the patients that they have noted to kind of go downhill quickly tends to be heralded by rapid changes in their lung ultrasound findings, particularly moving from B lines to more of a consolidative pattern. But I don't think that experience is shared throughout. So this question here I'll field from David. What's the difference between a fused B line and lung whiteout? I just want to clarify, if I did say lung whiteout, I meant white lung. And really there's, because lung whiteout usually more is a descriptive term for a chest x-ray. So the difference between a fused B line and a white lung is kind of rectangle square type thing. A white lung is the appearance in a single intercostal space of one giant fused B line that's giving the appearance of a sort of just general white appearance all the way in that intercostal space. So whereas you can have fused B lines that don't take up the entire intercostal space, and you wouldn't refer to that as a white lung appearance. And Keith has an example there of a nice fused B line causing a white lung appearance in that intercostal space. Thanks. Another question from Taylor, do findings change with proning? Since the findings are mainly predominantly posterior, how do these findings change with proning? Do you want to tackle that one, or do you want me to?
I'm not sure, so I think I'll leave that up to you if you have any information about that.
I'm not an intensivist and don't do a lot of or see a lot of patients who are proned, but my experience seeing patients who have been proned in other settings and not COVID-19 patients is that with ARDS, which is usually the reason you're proning them, a lot of the consolidations tend to shift to a expanded B-line pattern as the posterior areas sort of re-expand and open up a bit. And that is sometimes used to guide therapies. Hopefully in the next few weeks, we'll be able to have an expert critical care physician be talking to us about how they're using lung ultrasound to guide their vent managements.
And I would imagine that with increased recruitment, that you would have a change as well, from a consolidative pattern to maybe potentially more of a beeline pattern, just because that's what you see in atelectasis as well.
Let's see, from Ruben, Keith, has anyone looked at measuring pleural line thickness and determining pathology in a objective way?
So the like Dr. Wagner was saying, pleural line thickness has been reported, but several lung authorities believe that when it's an echogenic artifact of thickening that appears like it's thickening, that may just be an artifact and not actually represent pleural line thickening. And so at this point, I have not seen anything about people measuring the pleural line to determine severity. If that's what the question. Sorry, was that the question?
I think so. Yeah. This one from Nicholas. I understand pulmonary effusion is rare in COVID-19. Does this commonly present as hypoechoic and homogeneous? Should we think bacterial source or superinfection if the effusion is, quote, dirty? Yeah, I think this is a reasonable assumption here. This is that most viral associated pleural effusion should have a anechoic appearance to it and be relatively uniform. One thing to note though is that if you are really hunting for those trace small pleural effusions that hug the pleural line in between the intercostal space with a high frequency probe, they're going to be real tiny and easily confused with a subpleural consolidation. But if you are seeing large effusions, think not due to COVID, and then if you're seeing like the one Keith is showing there, and then if you're seeing septations and a more hyperechoic effusion, that would be less consistent with COVID-19.
And part of that is the septations and loculations in a pleural effusion are probably a product of time and inflammation. And so these effusions are not extremely inflammatory based on the experience in Italy. If you read that article that Dr. Wagner said was hot off the press by Dr. Volpicelli, his experience in Italy was that if there were pleural effusion septations or large echogenic content, that it was probably not from COVID-19 and that you should suspect superimposed bacterial infection or other inflammatory process.
We will do one.
We have
or
time
two.
for about 2 more questions.
Yeah, two more. Okay. Here's one about which frequency to use with a convex and linear probes from George. I don't know that a specific frequency is best, but when you're using a low frequency probe, I find that the artifacts are more prominent with a lower frequency. So certainly less than 5 megahertz for the low frequency probe. Usually, 3 seems to be pretty standard and adequate. For the linear probe, remember the higher the frequency, the less depth you get. And so if your question is really related to the pleural line at that higher frequency, if you can see the pleural line, the higher frequency is great. If you can't see the pleural line clearly, or if your question is whether or not, there's B lines and all you have is a linear probe, then the lowest frequency linear probe setting would be best there. And then let's see, is there any other ones we can do? Last one.
And also with the linear, just real quick, with the linear high frequency probe, if you are using that, make sure you increase the depth appropriately, because many of these point of care machines allow you to adjust the focal zone, and so it's automatically dialed in. And so often the artifacts appear better if you increase the depth along with that lower frequency.
Mm-hmm. And then let's wrap it up with this one. Keith, if you compare viral pneumonia and ARDS, is there any pearls about distinguishing the two of those disease processes.
At this point, I really don't think that there's a great way to differentiate it. If you look at the papers that have been published describing the findings in ARDS, you're talking about small case series of patients and not necessarily having a lot of controls. And so just anecdotally looking at these two processes, they appear quite similar. And so, you know, it's somewhat difficult to sort out. And there's a lot of clinical bias too, because you're there in front of the patient. So sometimes it makes you think that you're able to differentiate it better. But you know, I'm not sure that there really is a great pearl that I can offer there. Mike, I don't know if you feel differently.
I don't feel differently. A couple of thoughts. One is that with early ARDS, meaning the patient's first moving into ARDS, the findings may be very subtle and might not be as diffuse beeline pattern as you might expect. And that should be correlated with their degree of hypoxia and shunting that you're getting through, say, an ABG and PDAF ratios, things like that. But is also early viral pneumonia should also be relatively mild and patchy. And so it very much depends on where they are in their spectrum of illness. You know, the patient who has ARDS on day 1 looks pretty different on lung ultrasound than ARDS on day 5. And if you look at that study by Capetti, where they compared pulmonary edema patients to ARDS patients with, you know, the 100% sensitivity for B lines, those were all day 5 patients. So I think that's important to note. But the highlight there, I think, is that viral pneumonia does look very, very similar to ARDS, and some of the concepts and pearls that we're teaching you about ARDS can be extrapolated to viral pneumonias, and then the spectrum of illness really dictates the clinical course.
And one last thing just to put out there that could be a confounder is sepsis is the #1 cause of ARDS. And so if you have sepsis from pneumonia, you may have larger areas of consolidation or even multifocal areas of consolidation. So, you know, an undifferentiated sepsis where you're considering pneumonia, then that can make the determination a little bit more difficult as well.
Yeah. Unfortunately, we weren't able to answer all of the questions, but if you had specific questions that we didn't address and you would like to connect with us, feel free to send us an email. Thank you very much for your attention. Thank you to my co-presenter, Dr. Barron, and thank you, Darcy, for hosting this with the AIUM.
Thank you.
Yes.
And on behalf of the AIUM, our thanks to everyone who participated in today's webinar. Please remember to visit the CME Center on our website for the post-test. And we hope you enjoyed this presentation. Will join us for our next one next week. Have a good afternoon.
Thanks.